Today we are going to discuss about bronchiectasis in children as well as in adults. I think this is a very interesting topic. Why I am telling is I think before that we'll finish the definition of bronchiectasis. It is abnormal permanent dilatation of the bronchi, that everybody agrees that. And where it occurs in the medium size and large size bronchi. I think it's a little confusing. Actually, if you remember that it occurs in lobar bronchi, segmental bronchi and in subsegmental bronchi. I think probably around 2, 3, 4, 5 like that it happens, because last 7 divisions are respiratory bronchioles, and after 4 or 5 bronchioles are coming. Bronchioles are one that without any cartilage. So it is typically happen in the medium and large size bronchi. And sometime before when I talk, I always say it is an orphan disease, neglected disease, because if at all any disease that has little research is bronchiectasis. But of late, in the last 1 or 2 decades, there is a renowned interest in this field, and a lot of research is happening. That's what I am about to tell you in the beginning. Look at the prevalence of bronchitis in general population. It is not the child one, and because only in some part of the world correct census is available, and if you look at the United States, it is somewhere around 20%. If you look at the China and other places, it is somewhere around 13%, and United Kingdom it is around 11%. Okay, I think the why I am telling is it become very important talking, particularly after the corona epidemic, because this corona has damaged the lung parenchyma, and many of them gone far. Even children are developed bronchiectasis. Coming to the clinical features, we all know bronchiectasis means it is a one typically produced with a productive or wet cough, and it is the sputum is fetid, and I always say it is a postural related. When child get up from the early morning, there is a copious amount of sputum comes. Those days the usual question is in the exams, 3-layered sputum. What are the layer? If you collect the copious sputum in a conical flask, what are the top foamy layer, middle clear liquid, and the lowest one is the purulent sediments. It contains even the digit plaques. The digit plaques are nothing but crystals that contain a lot of debris, as well as bacteria, as well as some fat and other things. It may be foul smelling also. The most important clinical feature, if you look at if we go to the bronchiectasis patient, there may be halitosis, there may be a smell from the mouth, and clubbing is a very important finding that I am going to tell about something about. And auscultation, you can get a coarse, persistent, leathery rales. That's also they usually ask. Such a rales, that is a coarse, leathery rales, typically happen only in the bronchiectasis. It is why I put the slide is this is only for the students. Students may prepare for the exam. Clubbing is a reflection of undergoing or underlying hypoxia or underlying suppuration. That's the reason why they ask, will clubbing disappears in bronchiectasis? The usual question. Yes, if you have a effective postural drainage, I think it may reduce, or even after surgery it may reduce. That's what the answer. And how to know clubbing? Simple is a Shamrat sign. You just approximate your 2 index finger, and you can see the diamond in between. That is called Shamrat signs. In normal people, you will get a Shamrat sign, whereas in people with the bronchiectasis, it disappears. You cannot see that. Y means the hyponychial angle, that is the angle that forms between the nail and base of the nail. Normally it is less than 180 degree. In these people it may be more than 195 degrees. The other question is, sometimes they ask, it will go with the distal phalangeal length and interphalangeal length. So look at that, there are two vertical lines. Okay, we should make a first vertical line DPD, the second one interphalangeal, that is IPD. Normally DPD by IPD is less than 1. In clubbing it may be more than 1. That is also a very important one. Coming to the pathogenesis, the most important aspect in the bronchiectasis is the chronic infection. Actually, once the chronic infection settles, it may be due to obstruction or due to any causes, then there are a lot of neutrophil infiltrations, and these combine to cause peribronchial inflammation and impaired mucociliary clearance. Actually, the two important reflexes, native reflexes that protects the airway is a cough and mucociliary reflex. Actually, here the mucociliary reflex is deranged. That is the reason why child's cough every day, throughout, recurrent, chronic, whatever you call it, productive cough might be throughout the life. Cough is the one that compensates. And because there is a impaired mucociliary clearance, there may be excessive mucus. So these mucus, normally everybody produces mucus even to the tune of around 500 to 750 ml. Here there is an enormous one. So these mucus again become the nidus for the organism, and it on goes, like it becomes a vicious cycle, and there is a destruction of muscle and cartilage. Actually, the neutrophils plays a very important role, in the sense I am telling the destruction. Normally the neutrophil, even in a normal person, roughly 100 billion neutrophils are produced per day. In these people there is enormous neutrophils, and they are the suicide bombers. They want to attack the organisms, so they release a lot of neutrophil products, and like serine proteases, auxin free radicals, interleukin 8, and this becomes a mucopus. That's the reason why these people bring a lot of pus in the early morning hours. I think before going to the exact bronchiectasis, I want to say that this protracted bacterial bronchitis, usually we call it as a PBB, or chronic suppurative lung disease, or bronchiectasis, these are all form a spectrum. Actually, PBB represents one end of the spectrum, and the bronchiectasis in the other end of the spectrum. But if you look at the underlying mechanism, all the three have the same underlying mechanism, like airway neutrophilia, endobronchial bacterial infection, and impaired mucociliary clearance. That is the reason why nowadays our concept, because we don't know, 30 to 40% of the bronchiectasis, we don't know the cause. So you have to catch at the child in a protracted bacterial bronchitis stage. Any child having a cough, wet cough, you are not able to attribute to any other cause, and that has been present for about more than 3 to 4 weeks, you have to strongly suspect this PBB. Then you have to necessarily treat the child. That is very important. See, otherwise slowly it progresses to CSLD and as well as bronchiectasis. This is very, very important, and most of the times, sometime before even PB, we have done a lot of investigations. Nowadays they say even bronchoscopy and BAL is not required. You can straight away make a clinical diagnosis and treat, thereby you can prevent the bronchiectasis. Coming to the causes, the most important cause, I think the causes can be broadly classified into infections, obstruction, congenital, allergy, and aspiration. I think all are having, because most of the times in extreme stages they produce this bronchiectasis. Among the infections, the most important is the pneumonia, or sometimes tuberculosis. In developing countries, tuberculosis equally plays a role, and some necrotizing infections plays a very important role. Even the adenoviral insult cause bronchiectasis. Those days, pertussis, measles, and these days allergic bronchopulmonary aspergillosis, all these things, all these infections are slowly develop into bronchiectasis. And coming to the obstruction in children, foreign body and lymph node enlargement plays a very important role. And don't forget the congenital causes. I always say the PGs. Congenital means 3 C's are very important, 3 or 4 C's. Namely cystic fibrosis, ciliary dyskinesia, congenital immunodeficiency and congenital structural problem. If you remember, you won't forget. You can very easily answer. And even asthma, sometimes the difficult asthma, a small portion of difficult asthma may go into bronchiectasis. Particularly they say that either a right upper lobe, that is called Brock syndrome and other things. And aspiration, this is one thing we have to remember, particularly in older age or in a child neurologically impaired, they may go for recurrent aspiration that cause damage. In spite of doing all the investigation for this, namely infection, obstruction, congenital, I think 30 to 50% we are not able to establish the cause for the bronchiectasis. The bronchiectasis can be broadly classified in the focal bronchiectasis and diffuse bronchiectasis. That's the best way I am telling you. Focal means it may happen in the one lobe or one side, whereas diffuse one that happens in both the lungs. Whenever there is a focal bronchiectasis, you always think of infections, like what I said, and obstruction. That is very, very important. Congenital causes and immunodeficiency, allergy, these are all systemic aspiration, these are all causing diffuse bronchiectasis. Bronchiectasis involving both the lungs. Actually, why I am telling is, nowadays scientists argue or advise, if you diagnose the bronchiectasis in a very mild stage, I am going to show that bronchiectasis progress from fusiform or cylindrical, then it may finally ended in a saccular, in between cystic or something like that. So in a fusiform stage or cylindrical stage, that too in a very early, if you make a diagnosis, we could reverse small portion of bronchiectasis. Even though definition of bronchiectasis is abnormal permanent dilatation, I think scientists feel that if you make a early, because we have got a lot of, those days are different, and these days many things we have, HRCT, MDCT, so many things are available, and bronchoscopy is available. You can, if you make a diagnosis, there is a small portion might be reversible. That is very, very important. This only for our thing I showed, and we detected foreign body plays a very important role. That too, if the parents' literature is, I think they are not able to, if they are not, the fist of foreign bodies, only 50% have a typical foreign body history. The rest goes unnoticed. The parents may go for a work, they given the child to a people, child would have been put anything like that, like a groundnut, and that may go and settle down. And by the time parents, they totally forget what has happened. The cough may be there for about a few hours, and after that, what they say, it is a normal cough. They forget like that. And missed foreign bodies plays a very important role, and as well as that mucoid impaction, as well as lymph node enlargement. All these things are all slowly progress to focal bronchiectasis. Whenever you get a focal bronchiectasis, I think bronchoscopy is very, very important. I think these are the cases. Look at the third one, that is a fishbone. Actually, the fishbone in a gypsy child missed for a long time. Actually, the child comes with a right lower lobe bronchiectasis. I just simply done a bronchoscope. Then we are able to see this fishbone. How it has been there? Because the fishbone, in the central part of the fishbone, there is a small opening. So the child is nicely breathing through that. That is the reason why they totally miss the bus. So, and we diagnose, and probably after 3 to 4 years, once diagnosed, we removed it, and the child's life totally changed. I think tuberculosis, developing countries still plays a very important role. I have shown some of the X-rays. The right side, there is a adenopathy. Okay, lymph node may be enlarged, or it may be a segmental lesion. What is segmental lesion? Segmental lesion is nothing but a collapse consolidation. That is typically happens in tuberculosis. See, it all depends upon the bronchial pathology. Initially, the bronchial erosion might be there, some bacilli, that will produce consolidation. Finally, it end up in a collapse, and finally it go for a bronchiectasis. That's sort of the typical pathology happen only in bronchiectasis. Third one, you can see a very big consolidation with some sort of destruction. Cavitation is going on. All these X-rays are typically, if you're not diagnosed in time, you may go for a bronchiectasis. It's not bronchiectasis. I'm telling how tuberculosis is going for a bronchiectasis. I have shown some of the bronchoscopy views. Look at both the views. There is a caseating mass. Caseating mass is there, granuloma is there, and I think it slowly developed like that. At one point of time, it will totally occlude the lumen and it will go for bronchiectasis. I think this is, I only put for a student in exam. The examiner, MD, they're going for exam or DM exam, they'll ask syndromes. Because these are the syndromes historically discussed, particularly the William Campbell, Munir-Khan, Cartagenous, Young syndrome, yellow syndrome means bronchiectasis with the lymphedema. I think still, recently we published one article. And all these things, particularly Brock syndrome is very, very common because of all the three lobes on the right side, the middle lobe has a lot of disadvantages. Actually, the pores of Kohn and the lamps of Lambert, canals of Lambert, all these things are all not well developed in Brock syndrome. Anatomically, it has some lot of disadvantage. That is the reason why after tuberculosis and even after asthma, a difficult asthma, children will go for right middle lobe problem, that is called Brock syndrome. Coming to the investigations, I think I have shown the investigation. Of all the investigation, the most important is a MDCT with HRCT. Sometime before I have been talking only HRCT. Now MDCT. What is MDCT? I am going to talk about that. MDCT is an advance in the. It is a seventh generation CT. It has a lot of advantages. That includes HRCT also. And preliminary, we have to work for the right side investigation. Something like a sputum, MDCT, immunoglobulin assay, bronchoscopy, spirometry. These are all very, very important. Then depending upon the child's clinical presentation, and we have to go for sweat chloride, nitric oxide, ciliary studies, or aspergillus studies, and even sometimes we have to go for barium esophageography and all. I think followed a lot of children. I just showed one child with a bronchiectasis. It is a 12-year-old child. Look at that child, looks like a 6-year-old. A child presenting with a chronic cough, and because the child had measles in 1 year, and from that time onwards, it slowly developed chronic cough. The sputum also became productive. Slowly, child developed clubbing, and we have followed the child. The child developed typically after some time. Initially, start with obstructive nature of spirometry. Later, it developed both obstructive and restrictive defect, and that is what typically happening in a bronchiectasis also. And this is a child who have bronchiectasis of both lower lobe. Those days we have done all the investigation. To my knowledge, we have not come to the diagnosis. So chest radiograph in bronchiectasis picks up only some finding. If at all, some radiologists may say peribronchial coughing. If you are lucky, you can have the thickened bronchial may look like a tram track sign. Okay, these are the small findings may be only possible, or sometimes they miss foreign bodies. If it is going by radio opaque, you can see that. And more than that, you cannot make much in the chest radiograph. So that is the reason why people nowadays, sometime before we call it as a CT, HRCT. Nowadays, MDCT, if you order for a X-ray, you should always order for helical CT, that is MDCT with HRCT. HRCT is also included in the MDCT because it is a helical CT with a lot of, I think, multiple small detectors, and the spatial resolution is very good. And we can also can do some 3-dimensional reconstruction. These are the distinct advantages of the MDCT. And we can also, by adjusting that, we can get a HRCT, but only one collimation distance. We can make a slices at 1 millimeter level, thickness of 1 millimeter. The slices may be 10 millimeter interval. That is what sometimes we call it as a HRCT. That is also possible with MDCT. And some scientists believe, and if we are making a diagnosis of some congenital causes going for a bronchiectasis, I think some people will include even contrast. Why I am telling is, contrast picks up vascular etiology, vascular pathology, like abnormal bronchial veins or misalignment or all these things are all, and that also cause bronchial destruction, finally go for a bronchitis. So some sign, so it all depend upon the case, but generally if you want to make a final diagnosis, don't go for an ordinary CT, go for MDCT, that includes HRCT. MDCT, if you make a diagnosis, look at the pictures that I given there. It is nicely, you can see that thickened bronchial wall, okay, and peribronchial cuffing, thickened bronchial valve, and signet ring sign. You can see that. I am going to show that. Sometimes that bar, broncho-arterial ratio, what they say, I think that I will show in the next slide. Broncho-arterial ratio should be more than 0.8. In adult, anywhere between 1 to 1.5. In children, what they say, if it is more than 0.8, it says that it is a bronchiectasis. These are all in subtle forms of bronchiectasis, I am telling. There we have to use this bar ratio and all. And in typical cases, we will get finger in glow, mucus filled. These bronchus are filled with the mucus that gives a finger in glow appearance. Look at the right side. I have shown 2 CT. The first one is the upper one that involves the right middle lobe, maybe bronch syndrome going for a bronchiectasis. The second one is the left lower lobe with a lot of cystic dilatation. Probably it is both of them are established. They are all saccular bronchiectasis. I think some people or some PGs may be interested. What is bar? Bar mean it is a ratio of inner diameter of the bronchi to the outer diameter of the artery. Can you see that? And there is a nice signet ring appearance. Look at that. This is the artery. This is the bronchus. Look at the nice signet rings. This is very typically I taken from the net. And this is a signet ring appearance. Something like we bird as a signet ring, no, like that it resembles. And the ratio between this artery and the ratio between the bronchus and the artery, if that should be more than 0.8. And even in mild forms of bronchiectasis like bronchial thickening and peribronchial thickening or tram track signs, all these are all possible with the MDCT. I think this is a very old classification, still holds. Bronchiectasis can be, actually this is done by the Lanak, I think. He has done this sort of a classification after studying lot of bronchiectasis, probably in the post-mortem child or adults dying due to bronchiectasis. We have to salute this man, Lanak. I think he classified the bronchiectasis in the cylindrical, varicose and cystic. Actually this is a very mild form. Sometimes it is used to call it as fusiform. And this is a varicose one, beaded appearance. And cystic, it is also called as a saccular bronchiectasis. This is a very worst form of bronchiectasis. You cannot do anything. It is very difficult. These all are very, shows the dilatation of the bronchi. Probably it is the initial stage, then slowly progress to varicose, then cystic or saccular stage and all. Coming to the anatomy, sometimes bronchiectasis can happen in the lower lobe, middle lobe or upper lobe or in the central bronchi. All these things will tell the possible cause of or it may suggest. I am not going to tell, you cannot make a diagnosis. For example, anything that happened in the lower lobe might be due to the infection, recurrent infection or aspiration. In the middle lobe, bronchiectasis always there that tuberculosis. Or it may be in developing countries like a primary ciliary dyskinesia. Upper lobes are typically involved in the cystic fibrosis. Sometimes cystic fibrosis is the one that produces non-segmental distribution of the bronchiectasis. I think it's a very, very important one, non-segmental. It doesn't follow the segmental distribution. There is a non-segmental distribution. Finally is ABBA, allergic bronchopulmonary aspergillosis. I think recently we have a lot of interest in this one. It typically involves central bronchi. Look at that. Can you see the central bronchi? Central, it's not in the periphery. It is happening in the central. That is what goes with the allergic bronchopulmonary aspergillosis. Coming to the treatment, why I put this one? If you remember that the pathogenesis of bronchiectasis, the treatment becomes very easy. See, the pathogenesis is something like a vicious cycle. It starts with the chronic bacterial infection, then it will go for peribronchial inflammation, then it go for damage of the mucociliary mechanism, lot of accumulation of the mucus, and it will go for a structural disease, and again it goes in the same direction. This is a vicious cycle. We have to stop that. So you have to stop at all levels, of which many people you have to necessarily treat the infection first, and you have to clear the accumulating mucus. That is very, very important. So the treatment of bronchiectasis can be broadly classified in the airway clearance, that includes postural drainage and chest physiotherapy. Actually, chest physiotherapy includes postural drainage and various manipulation techniques that I am going to discuss, and mucoactive agents. And no doubt, nutritional support plays a very, very important role, especially in the management of cystic fibrosis related bronchiectasis. And rehabilitation, I think we can advise all this we are going to talk, and naturally vaccines also plays a very, very important role. Coming to the pulmonary exacerbation, actually children with the bronchiectasis repeatedly go for typically go for exacerbation. They have an increased cough, they may have an increased sputum quantity, the purulence may be increased, or sometimes the rate may be increasing, dyspnea may be increasing, even if you're done, CRP may be increased, there may be new infiltrates. All these things are all, sometimes they may experience a mild fever, fatigue, all these things. So that shows that that particular child with a bronchiectasis is developing exacerbation. And once exacerbation occurs, probably I said it typically due to the bacterial organism. Typically due to bacterial organism, particularly in non-cystic fibrosis, that is non-CF bronchiectasis, a common organisms like a Streptococcus pneumonia or a non-typable H. influenzae, Moraxella, these are the common organisms. Whereas in CF, I think you should always remember Staphylococcus and mucoid forms of Pseudomonas aeruginosa. I think this knowledge is very, very important. So in a normal child, that is what I normal the child, bronchiectasis in a non-cystic form, the choice of antibiotics is typically after sputum culture, but many times it's not possible. You have to start empirical therapy. So in that way, the ideal one is if you are admitting the child, either a child you can use co-amoxicillin or ceftriaxone. But if you admit the child, the antibiotic should be used for at least 14 days. And before discharge, ideally, or after 1 month or something like that, you have to retest the sputum. Why I am telling this? These bronchiectasis, particularly non-cystic fibrosis, or even cystic fibrosis, they develop Pseudomonas that has to be treated or eradicated very fast. Otherwise, that I am going to show that most of the CF bronchiectasis typically acquire Pseudomonas very early. This knowledge is very important. Once you are able to, if the sputum culture shows Pseudomonas aeruginosa, either a normal spontaneous sputum or induced sputum or BAL, if it grows Pseudomonas aeruginosa, you have to necessarily eradicate. You should not say that it may not damage or something like that, because what the recent literature says that, and by virtue of producing biofilm, and it causes a structural damage. It increases the structural damage. That is the reason why when Pseudomonas aeruginosa happens or colonize the bronchus, there is a 7-fold increase in the expiration, 3-fold increase in the mortality. I think this is very important. So that is typically happen or very early happen in a CF related bronchiectasis. So you are able to you are growing Pseudomonas aeruginosa in a culture. Then look at the patient clinical situation. Clinically the patient is a stable one. You use oral ciproflox for 2 weeks. Then there is a questionable role about the nebulization, but still many people use tobramycin for at least 3 months. That is a very important one. Well, if the child is developing pseudomonas but child is also symptomatic, acutely ill, you are admitting the child, you have to necessarily start with the intravenous broad spectrum antibiotic that cover the pseudomonas like piptas or ceftazidime. That is very, very important. After that, you can also use the nebulized tobra or colistin for some time. I think what I want to say that those days pseudomonas means everybody thought no, you cannot, like some people ignored, some people it is happened means everything is happened like that and all, but it's not so. What research shows that you have to follow this one. Once you follow, you can able to eradicate Pseudomonas aeruginosa, because Pseudomonas aeruginosa one will produce a lot of it increases the both mortality and morbidity. Coming to the airway clearance therapy, ACT, we can broadly divide into chest physiotherapy and along with some mucoactive agents that I am going to talk separately. Among the chest physiotherapy, the most important is the postural drainage. Actually, when I happen to be in the government service and I have seen a lot of poor children come with a bronchiectasis, I think postural drainage helped a lot, because otherwise they will be repeatedly getting admitted. So it should be combined with all percussion, active cycle of breathing, PERT devices. I think these are the ones that I am going to talk about that. And wherever possible, mucoactive agents can be used, but there is a lot of research is going on whether to use, what is the usefulness of mucoactive agents, whether they are really useful or you are spending a lot. I think that I am going to show in the future slide also. One thing that I want to say that if the early parents should be made to learn these techniques, chest physiotherapy, because even though in developing countries is different and developing a situation in the developing countries is different. In developing countries, a lot of physiotherapists is available, you can utilize them. Whereas in developing countries, you have to make the parents to know how to use this postural drainage and all. What is chest physiotherapy? Chest physiotherapy, it is nothing but an airway clearance technique that combines various manipulative procedures, including positioning. That is sometimes we call as a postural drainage, and along with that, chest percussion, vibration, thoracic squeezing and cough stimulation. I think these are all typically done by the physiotherapist, and what we do as a positioning, that is very, very important. And actually physiotherapists will teach them breathing exercises also. In that way, it helps a lot. And coming to the postural drainage, I said I am a very strong or a staunch follower of this postural technique. Actually, the middle and the lower lobe. For example, in the right side, there are 3 lobes: upper lobe, middle lobe, lower lobe. The middle and the lower lobe do not have the advantage of gravity drainage. Actually, these lobes drain from from down to up, something like a escalator. The mucociliary escalator takes the sputum from lower lobes and it goes to the throat. And after that, I am telling about the normal child. The mucociliary system is the one that very nicely operates. It takes the sputum from the lower lobe, middle lobe. It acts like an escalator, and when the sputum reaches the throat, and adults, they usually cough up, whereas children will swallow. That nice mucociliary escalator mechanism has been spoiled in the bronchiectasis children. That is the reason why when you child develop the problem of bronchiectasis in the middle and lower lobe, we should have the advantage of gravity. So you should make the child to lie down like this. That is a foot end should be elevated. How much elevated? It all depend upon the lower lobe or middle lobe. Lower lobe, this 18 inches elevation is very, very important. Whereas in the middle lobe, 14 inches or lingula is involved, 14 inches elevation is enough. And we have to keep the child at least for 45 minutes or 30 to 45 minutes. This is a very important one. Actually, there is a very nice article appeared in Indian Pediatrics in 2005. this is a nice diagram how to you can go through that, how various techniques can be used that may drain the reference segments. We know the right lower lobe means there is maybe a what so many segments, that is anywhere between middle lobe means upper lobe 3 segments, middle lobe 2 segments, lower lobe 5 segments. On the right side I am telling how to drain these segments, and that is the way you can go through this, and any child, this knowledge will help you. Again, before doing cupped hand percussion, you have to delineate the segments. You have to make a surface topography. Actually, this is a usual question, how to do a cupped hand percussion. We have to do a cupped hand percussion like that, and I used to teach 3 per second, 3 minutes per segment, 30 minutes per session, because you cannot be doing for 1 hour or something like that. And if you do like that, child will be very tiring, child will be getting exhausted. So it can do at least 3 times per day or at least 2 times per day. And ideally it should not be done, ideally it should be done 30 minutes before meals, or if the child is taken the meals, it should be done after 1.5 hours after meals. These are all the very, very important one. Actually, this is one of the child, I still, the childs who have done a lot of posture. Actually, in our hospital, a lot of poor children will admit, and we can utilize the available facilities. And they are very poor children, they cannot go to physiotherapists, and the mother learned the technique from us. And after the recurrent exacerbation is drastically come down. This is very, very important. So what I want to say is, chest physiotherapy is the one that typically combines postural drainage and cupped hand percussion. Okay, and it all depend upon the elevation should be depend upon the middle lobe or lower lobe. 14 inches for a lingula and middle lobe, 18 inches for the lower lobe. And I already said how to do a cupped hand percussion and all. The goal of therapy is to mobilize the secretions. That is very, very important. So if you because since the mucociliary escalator mechanism is not operating, there is lot of accumulation of the mucus. So you have to mobilize the secretion, and the child should bring out all the accumulated secretions from the lower lobe or middle lobe. And that is, if you make like that, typically the children may not go for exacerbation and all. In upper lobe means, upper lobe always drains from above downwards. It is something like above downwards. Okay, it have the advantage of gravity. So not necessarily put the child on any elevated positions, but that I show that. And since it have the advantage of gravity drainage in all the positions, either as erect or semi-erect or sitting position, you can do like that. But in some other condition, child may develop bronchiectasis in the upper lobe, you can simply do like that. This should be combined with the percussions. And infants, you can use this mask. Actually, the mask can be used, and the air column inside the mask effectively dislodge the sputum. That's very, very important. You put the child on your lap, and you can do like that. I always fashion of active cycle of breathing is a very, very important technique. I think recently it helped a lot, because it can be done at any time, and even the child in the while watching a TV, you can make the child do ACB, active cycle of breathing. Actually, this combines 3 techniques: relaxed breathing, deep breathing, and offs. Actually, when you take a breathing, if you take a breathing in, it has to be done through the nose. While you breathing out, it has to be the mouth. This is a simple principle. While you take the breath in, it has to be done through the nose. Whereas if you want to breathe out, it should be done through the nose. So initially, to start with a relaxed breathing, to have a breathing control, then slowly you have to deep breathing with a 5 minutes. You have to hold at least 5 minutes, 5 seconds. You have to hold the breath in between like that. So 3-3-1. Each cycle is 3-1. The relaxed breathing is a 3-1, followed by 3-1 deep breathing, where you have to hold the breath for at least 5 seconds, and then it should be followed by hops, where force expiration to move the secretions from the lower airway. It can be done. Only thing is, you have to take a time and teach the children. I think airway clearance devices may not be useful, may not be necessary for a non-cystic fibrosis bronchiectasis. Actually, that's I want to touch upon children with a cystic fibrosis going for a bronchiectasis. These clearance devices might be very useful. The two popularly used devices are, one is the acapella and flutter valve. Both are available and you can get it. And because child may, father may want to do they may do anything to make the child little comfortable. So both the instrument, in both the instruments, the child exhales into the devices. So child produces a positive expiratory pressure against the resistance. Look at the moving steel ball. You can see the steel ball here. So here the child exhales into the instrument and create a positive expiratory pressure that causes the ball to vibrate rapidly. Only thing is, in acapella can be done in any position. Even in a lying position the child can do. Whereas if you use a flutter valve, it has more efficacy wise is better, but it can be done only in the erect positions and all. The West one, it is very costly one. I want to just touch upon cystic fibrosis going for a bronchiectasis. You can purchase the West, and it is a mechanical device, and the patient should wear a jacket, something like that, and it should is hooked to the pulse generator. It produces both positive and negative pressure, and in that way it inflates the West and deflates up to 20 times per second, and this causes the effective dislodgement of the mucus from the bronchial valves. I think it's a very, very costly one, and probably in cystic fibrosis centers they are advising this, and not for the regular or non-bronchial. It can be used only in cystic fibrosis related bronchiectasis. Coming to the mucoactive agents, I do not touch all these things, but when I go through the literature, I think none of them are very useful, either in a CF bronchiectasis or non-cystic bronchiectasis. Only two things that is going to be very useful are hypertonic saline and beta agonist. Actually, most of the times people say that give beta agonist and do give a hypertonic saline, that cause a effective dislodgement. You can do, actually when it is indicated means typically these two agents are indicated during the once your child comes with the exacerbation, started the treatment, getting stabilized, you have to do this sort of a hypertonic saline and beta agonist. 3% hypertonic saline, some people also use 7% hypertonic saline, and it creates a osmotic gradient by absorbing fluid from the interstitial space and thereby making sputum less mucus. And the child is, because in these bronchiectasis or cystic fibrosis bronchiectasis, the secretions are very, very thick. So you have to loosen the secretion. So in that way, both 3, 7, I always favor this 3% hypertonic saline, and on some of the papers says that if they regularly do this one during exacerbation, the structural lung damages can be minimized. That's what is being reported in a Cochrane database also. I think cystic fibrosis is a different one. You have to naturally put the child on pancreatic enzyme replacement therapy, at least 10,000 units of lipase per kg you can use. And these cystic fibrosis bronchiectasis children, because of the pathology, cystic fibrosis pancreatic pathology, they need fat soluble vitamins like vitamin A, D, E, K. This knowledge is very, very important. And both cystic fibrosis related and this non-cystic fibrosis, these children should be benefited, or these children will, even if they miss early normal vaccine, you should advise depending upon the catch-up vaccines for pneumococcal or a varicella or influenza vaccines should be given. And what they say that these vaccines is very useful even in the bronchiectasis, especially if they are not taken initially and all. Coming to the surgery, before, I think surgery is very hardly required, and in my because I happen to be working in public sector government hospital, I have subjected few children for a surgery, particularly in a localized bronchiectasis. Or if the bronchiectasis is due to distal foreign body that cannot be removed by a rigid bronchoscope. I think these are the two. Sometimes localized disease with a recurrent hemoptysis also possible. In these are the condition we have to go for a surgery. It's a very rare phenomena, but as far as possible we have to delay the surgery up to 12 years, and you have to continue the medical treatment for at least 12 years. Once they become adolescents, you do a surgery, because then their complications will be very, very less. They will have a very normal life. And before doing surgery, you have to do FEF. Actually, this FEF1 should be more than 40 to 50%. If it is less than that, you have to be very careful, because you have to do all the medical treatment, and you can make the child FEF1 above 50%, then only you go for a surgery. And if it is going to be a bilateral bronchiectasis, I think surgery is contraindicated. Coming to the last, it might be a last slide. What is the message? In bronchiectasis, the early diagnosis is very, very important, and identification of the cause is very important. Today, MDCT, that includes HRCT, also major place in the early diagnosis of the bronchiectasis. In the management, in addition to the antibiotics, the most important is the postural drainage. That airway clearance techniques is very, very important. Don't forget about the nutrition, because these children, they lose a lot of proteins. So you naturally put them on good nutrition, and don't forget about the pancreatic enzyme replacement therapy and vitamins in CF related bronchiectasis. I already talked about the vaccine. And if it is going to be a local surgery, I think when you follow the child till about 10 to 12 years, then it should be done only in the tertiary center, because lung surgery is always a very difficult one. We have to have a thorough understanding before we should give a roadmap to the surgeon. What is the segments involved? What is the lobe involved? That is very, very important. I thank all these scientists, because they have done excellent work on this neglected subject. I think you can go through these recommendations. Recently, some recommendations also come in the last 3 years. You can go through that, and I think we will make the child, if you follow this protocol given by guidelines given by, child will have a normal lifespan. Thank you very much for the listening and all. Okay, thank you very much, and I will stop that sharing the slides and all. Yes.